I'm Fiona Clement. I'm a professor and the department head of community health sciences at the University of Calgary. And my own research centers around supporting evidence-informed policy development in response to government priorities. So I have the privilege of working very closely with many colleagues in government, and it's been an incredibly rewarding experience so far. Through that, I spend a lot of time thinking about healthcare structures, value, and reforms. And in Alberta, it's kind of a wild ride right now. Last year, I had the privilege of delivering the Crichton Lectureship, which brings with it the wonderful invitation to introduce this year's Crichton Lectureship awardee. And I mean, who could pass on the opportunity to introduce an accomplished colleague? So I'm very pleased to be up at the podium this morning. Just a little bit of history about Dr. Crichton. She was a professor here at UBC from the late 60s to the mid 80s in what then was the Department of Healthcare and Epidemiology. Imagine being a healthcare systems scholar during that time. So this is pre-Canada Health Act, in the conversations really leading up to perhaps the most significant piece of healthcare legislation that we have had in this country. The conversations were about provincial and federal responsibilities, patients facing increasing financial pressure, a workforce that was not fit for purpose, and accountability between the feds and the provinces for taking reins of these kinds of issues. That might sound a little familiar to some in the room. And at that time, that conversation led to the Canada Health Act. And for me, that's a very inspiring thought to think that perhaps these conversations that we're having with such vigor right now might lead to a piece of legislation as significant as that was back in '84. And if you read some of Dr. Crichton's writings, you will see that many of the ideas are things that we're talking about again today. So she was talking a lot about community models of care, conceptualizing primary care as a team beyond just a physician, and recognizing that citizens and patients must be at the center of decision-making in whatever that next step was. Dr. Hsu, who was one of Dr. Crichton's students, whose journey took a completely different turn due to a class with Dr. Crichton, and was inspired as a response to endow this lectureship, perhaps summarized her work best, saying, one of the key takeaways from Dr. Crichton's teaching was that rational healthcare planning from an ivory tower is seldom successful. And where has that lesson been laid so plainly bare other than healthcare, where we have had many conversations from an ivory tower perspective for probably close to 60 years and have yet to really push forward into significant implementation. And so with that backdrop, it is an absolute pleasure to introduce Dr. Katherine Boothe, who's this year's Crichton Lectureship awardee. Dr. Boothe is an associate professor in the Department of Political Science and a member of the Center for Health Economics and Policy Analysis, or CHSPR, at McMaster. Her book, The Ideas and Pace of Change, compares the development of public pharmaceutical insurance programs in Canada, Australia, and the UK in an attempt to explain Canada's lack of broad public pharmaceutical insurance. And building off of that work, she's written many articles which have set the stage to learn from the history of Pharmacare, which brings us to today's conversation. Dr. Boothe is an accomplished scholar, a passionate educator, and this lectureship is a bit of a homecoming for her as she returns back to UBC, where she completed her MA and her PhD. And she shared with me this morning on her bus ride in, she passed her old apartment, which is still standing. And so with that, I'd like to congratulate Dr. Boothe on being selected for the Crichton Lectureship and welcome her to the podium to deliver her lecture. And I've lost her, where is she? Oh, there. Thank you. That looks dangerous.
Good morning, everyone, and thank you very much for that introduction. I'm really pleased to be here. It is a privilege to be giving a lecture that honors the work of Dr. Anne Crichton, and to be following Dr. Fiona Clement's inaugural lecture at this conference last year. Whoops. Can you hear me okay? Is like a bit of an echo? Okay. I'm going to try not to break any technology while I'm standing up here. This morning, I'm going to provide what I hope is a useful starting point for the day's conversations by looking at the history of Pharmacare, proposals in Canada, and considering what lessons they might have for our current moment of reform. I should have asked, is this my clicker? All right. Okay. I'm going to start by giving you a bit of my own context for doing this work. I began studying pharmaceutical policy as a PhD student here at UBC. I didn't come into it with a lot of background knowledge about Pharmacare. I was just looking for a puzzle and a dissertation topic that would allow me to investigate the interaction between institutions and ideas in understanding policy outcomes. And I found that. And through this research, I also came to my own set of ideas about what makes for equitable, effective, efficient pharmaceutical policy. As Fiona kindly mentioned, I wrote a book based on my dissertation, and that was published in 2015. And sort of one of the big takeaways from the book was that incremental policy development tends to stall for predictable reasons, and that limited ideas about pharmaceuticals as a policy problem is a key barrier to change. I'm going to come back to this argument in some detail because I do think it's relevant to the current moment. From 2015 to today, we have this really interesting wave of salience, more public debate, and new policy proposals for Pharmacare in Canada. During this time, I became interested in patient and public involvement in pharmaceutical policy and in health policy more broadly, and that has become an important part of my research. A few years into this newer research program for me, my younger child was diagnosed with type 1 diabetes, which first meant that her dad and I spent a bunch of time learning how to be a pancreas. Got the two key type 1 technologies there, insulin and juice boxes. And another effect of this was to reinforce my research perspectives on the equity aspects of pharma and the crucial role for patient and caregiver involvement in health policy decisions. And I mention this because in a field like ours, I don't think it's unusual to have some version of a personal stake in the area where we are working or researching. We're all health system users and pharmaceutical consumers at one point or another. I think it is useful to foreground the way my particular experience and research expertise coincide to shape both my commitments to pharma policy and the types of questions that I ask about it. So this is where I'm coming from. In terms of where I'm going this morning, I want to first review the sort of earliest history of Pharmacare failures and discuss the way limited and frankly evidence-free ideas about the cost of drugs contributed to policy failures at this time. Second, I want to consider Pharmacare events since 2015 and pay attention to continuity in public and political conversations between the first few decades of Pharmacare policy proposals in Canada and interventions since 2015. I'm particularly interested in the way issues of evidence and legitimacy play out here. For my purposes today, evidence means empirical information about how policies work. Who's expected to benefit, who absorbs costs, how certain policies affect the distribution of costs and benefits, and so on. By legitimacy, I mean the ways that ideas are accepted by policymakers and the public. What makes certain types of evidence trustworthy or acceptable? And what legitimation strategies can help bolster the acceptance of new ideas and counter old ideas that might be based on misunderstandings or incomplete information? My main argument is that ideas are sticky, and they don't necessarily have to be based on quote unquote good evidence in order to be sticky. Legitimacy can also come from long repetition. Being attentive to this may give us insights into the potential barriers to reform that are facing pharmacare today. So we will start at the beginning. My guiding question in my previous research on pharmacare was, why don't we have it? As you all know, it's not for lack of trying. There were a number of proposals for nationwide pharmacare since the 1943 Marsh Report assumed that drugs and medicines would be part of a comprehensive public health system. Few important milestones. We have the Hall Commission in 1964. We have an internal federal cabinet memo proposing a universal pharmacare program in 1971-72. We have the National Forum of Health in 1997, and the proposals for catastrophic drug coverage from the Romano and Kirby reports in 2002. So the content of these proposals was quite different, and they were made in very different political and economic contexts, right? They're made in moments of sort of economic and fiscal distress and moments when things were pretty good. None, obviously, produced major reforms. And so we can look at this and say, well, is it because drugs became more expensive after the therapeutic revolution picked up in the 1960s? Is it because pharmaceutical and private insurance industries became stronger over time and offered opposition? Is it because provinces couldn't agree? Some of these factors are relevant at different points in time, but I find there's a crucial prior barrier to the serious consideration of these reforms, and that is the types of ideas that politicians and the public hold about health policy in general and pharmaceuticals in particular. And it's a reciprocal relationship between elite ideas and the public's perceptions of an issue. The common threads in all those moments of reform that I just listed are, first, the types of ideas that politicians expressed when discussing them. Pharmacare is consistently viewed as fundamentally unaffordable, as an add-on rather than a core health service. And this is often expressed as the need to focus on fixing what we have rather than adding something new. Additionally, we see a strong commitment to incrementalism. Health policy development in general and pharmaceutical policy specifically are seen as risky and something that should only proceed in steps or stages. The low public salience of the proposals is sort of the other half of this barrier. Limited ideas on the part of policymakers and politicians shape public demand. The public does not tend to demand specific benefits in a complex and unfamiliar policy area without some elite prompting. And this lack of public demand can then reinforce the low priority position of pharmacare on government agendas. And so I want to give you some examples of these two types of ideas about costs and incrementalism. So at the 1950 Federal Provincial Conference, the National Department of Health and Welfare recommends leaving pharmaceuticals off the agenda because, quote, all experience to date indicates that it is almost impossible to control the cost in such services. A 1963 federal departmental group to study health insurance, which was working at the same time as the Hall Commission, but this memo is from before the Hall Commission released its report, said that in view of the difficulties inherent in the control costs, and in light of the availability of drugs provided in hospitals, right, this is post-hospital insurance, that pharmaceutical benefits might be excluded from any Canadian medical care program. The 1971 internal proposal by the Ministry of Health for a universal Pharmacare program, as far as I can see, never really made saw the light of day, right? It's something that we can find in the archives. And in a cabinet meeting to discuss the proposal, then Prime Minister Pierre Elliott Trudeau said he did not wish to extend Medicare to drugs because of the considerable expenditures involved and the difficulty of getting provinces to pay their share. And so I want to emphasize here, yes, there were a wider range of more effective and more expensive drugs available by the time of the 1971 proposal. But before this, there doesn't seem to be a lot of evidence that drugs would represent a fundamentally different problem for cost control than other health services. So I have a shorter list of examples about incrementalism. The first one is a hometown example. At a federal provincial conference in 1964, British Columbia advocated for a health insurance program designed in such a way so as to permit step-by-step implementation. And by this, they meant medical, pharma, dental, and other services. This idea and even the phrase step-by-step was present in the earliest post-war discussions of health insurance at the federal level, as well as later proposals, like the 1972 internal proposal for universal pharmacare. So by this time, the proposal had been modified to a staged program that would provide drug coverage to seniors and eventually expand to children and other groups. Ultimately, of course, it didn't go forward. And it's not really clear where these limited ideas came from, especially in the 1940s and 50s. But I think it's important to realize that they do not seem to be based on evidence. The archival records contain almost no references to the experience of other countries who were implementing pharmaceutical benefits at this time, like the UK or Australia. There's certainly not the type of cost estimates that we see today, or really any attempts to systematically analyze potential costs. Pharmaceuticals were taken off the agenda before that type of work happened. And both these sets of ideas about the unaffordability of pharmaceuticals and the need for program development to proceed incrementally put constraints on reform. Ideas about costs contribute to a cautious step-by-step proposal, and the lack of ambitious ideas from policymakers and elites dampen the possibility for public demand and political will to develop. And this dynamic carried through later reform proposals. So now I'm going to skip ahead a bit. At the time my book was published, my main takeaway with regards to reform was that ideas have to change. Reform efforts have to address ideational barriers as well as institutional or financial barriers. Going back to the theme that I introduced at the beginning of the talk, I thought that better, publicly accessible evidence about how good pharmacare systems work and how much they cost would be an important tool in prompting ideational change and in resetting that knee-jerk reaction that pharmaceuticals are unaffordable in a way that other health services are not. And I was not alone in this thought, I think. So in 2015, we have an important publication from Morgan, Law, Daw, Abraham, and Martin on the estimated cost of universal public coverage for prescription drugs in Canada. And then subsequently, scholarly publications from a variety of authors and disciplines. Also in 2015, the Pharmaceutical Policy Research Collaboration released the Pharmacare 2020 report, an important example, I think, of research advocacy. In 2016, 100 years off there. The House of Commons Standing Committee on Health, or HESA, begins hearings on the development of a national pharmacare program. It requested a parliamentary budget office analysis, which was released in September 2017 and updated in October 2023. HESA released its final report in 2018. And then, of course, in 2019, we have the Advisory Council on the Implementation of National Pharmacare, or the Hoskins Report. So there has been a flurry of activity around pharmacare. The first timeline I showed you covered almost 60 years, and this is less than 5. Arguably, pharmacare is more salient than ever before, and also there's higher quality evidence available about how different policy options could work and what implications are. I think it's interesting to note in this, in these pieces of research and study that I have put up here, there's a fair amount of expert consensus about this evidence. Costs can be managed. There are potentially important cost savings to a universal system. And although, as in any policy, we need to pay close attention to trade-offs, some form of pharmacare is something that we probably have the capacity to do. It's not impossible in a way, again, that other health services or other social programs are also not impossible. With this generation of evidence, we can also think about legitimation efforts. The research estimating costs was published in the CMAJ, the flagship journal of the Canadian Medical Association. The Pharmacare 2020 report was accompanied by a letter signed by, at the time, over 300 academic experts. I think it's now more than 1,000. I signed the letter. I imagine many of you did as well. The HESA report was a multi-party effort that heard from almost 100 witnesses over 2 years. The Advisory Council spoke to more than 1,000 Canadians over the course of a year. So the evidence that was produced about the reality of cost barriers to pharmacare, among many other factors, was good. It was rigorous, it was well publicized, and it drew on existing systems of expertise and legitimacy. But I'm not sure it worked, or it might not have been enough. And before you think I am being overly dramatic or pessimistic here, I do know there have been some really interesting proposals in the last few years, particularly at the provincial level. And I did see there was a big announcement about pharmacare last week. But I also want to point out that although the policy recommendations from places like HESA and the Hoskins report differ from past proposals, they are broader, they are more detailed. I think they're arguably more radical than Romano, Kirby, or the National Forum on Health. The reaction from the federal government has been very much in line with historical precedent. Immediately after the release of the Hoskins report in 2019, then Finance Minister Bill Morneau told the Economic Club of Canada that a national pharmacare program would be fiscally responsible and would deal with the gaps, but doesn't throw out the system that we currently have. In the lead up to last Friday's announcement, Federal Health Minister Mark Holland's response to the PBO estimates repeatedly stressed the need for fiscal prudence and emphasized that the federal government would not be able to afford to shoulder the entire projected cost. Finance Minister Chrystia Freeland assured Canadians last month that pharmacare will not jeopardize Canada's fiscal standing. And in the February 29th announcement of Bill C-64, we see a lot of emphasis on the need for bilateral agreements with the provinces and a focus on step-by-step development and rollout of the plan. These ideas about runaway costs are sticky, and we see them in public conversation before we even know really many details about how the funding arrangements for these programs would work. This is not to say that policymakers should throw full and constitutional caution to the wind in considering pharmacare. It's just to point out the continuity in the framing of Pharmacare proposals over time. New proposals, similar reaction. So, new evidence doesn't necessarily or automatically result in ideational change. Even with better evidence, ideas are sticky, particularly when public salience is still relatively low and the broader policy area has a lot of competing priorities that are more salient. Even though the most recent proposals for Pharmacare are different, and they are occurring in the context of a different environment for evidence, other important elements of the policy context may be similar to those that we have seen in the past. So I suggested this thing that more, better evidence about the benefits of Pharmacare reform is not enough to achieve major reform, or at least evidence in the ways that we might traditionally think about it is not enough. I do think that considering the ways ideas are legitimized or delegitimized can be helpful, and so that's what I want to finish my time talking about. I won't make predictions, but I will suggest some things that I think deserve our attention, and I'm looking forward to hearing what you think about this. First of all, I think it will be important to consider ideational change as part of social learning that goes beyond those of us who are considered experts or who fall within a relatively narrow definition of stakeholders. We all, meaning all Canadians, have to understand ourselves as players in Pharmacare policy, as people who pay for drugs one way or the other. And that might prompt different conversations about the types of trade-offs involved in major Pharmacare reforms. The way policymakers and experts talk about the scope of reform is important, especially as more details of the implementation of Bill C-64 are worked out. The bill uses a language of universal, first dollar, single payer coverage, which is great, in my opinion. But those words might generate specific expectations for Canadians who are used to hearing them in reference to public hospital and medical insurance. If the reform is framed as radical, but does not address the scaffolding that makes our current pharmaceutical systems segmented and multi-payer, there is a risk, I think, involved in overpromising and under-delivering when it comes to developing public salience and support. This is related to the second idea that I suggest researchers and policymakers and reformers consider, the issue of government capacity and trust. I've talked about the importance of political will and the role of broad public support for reforms in terms of generating political will. Current polling data does not seem to indicate really deep or broad public support for major Pharmacare reforms. It's just not a priority when we look at what Canadians are worried about when it comes to health. And I think it'll be difficult to develop that kind of support if the public does not believe that governments can pull off Pharmacare. I think there's a potential for Canadians to take lessons from the rollout of the new Canadian dental care benefit about the federal government's capacity to implement new health benefits. And we should pay attention to the ways the CDCB and other programs, perhaps including this new coverage of contraceptives and diabetes medications, may enhance or detract from government's legitimacy as health system reformers. The federal government has given itself a long lead time for the potential implementation of this new coverage. And so it's worth asking if the work they will undertake in this area over the next year or so enhances public trust. My takeaway this morning is that, I think I have another slide for that, good. My takeaway this morning is that if we put the current reform period in historical perspective, we see a fair amount of continuity with past reform efforts. My hope is that in recognizing this, we don't just continue to go over the same ground, do the same studies, and make the same arguments. We don't know how the details of Bill C-64 will take shape, but if we are attentive to stumbling blocks from the past, maybe those details can take public drug coverage further than it has gone before. So I'll end there, and thank you for your attention.
All right. I think we are doing questions now. Thank you for that awesome lecture, Katie. Okay. So we are using Slido this year as we have for many, many years. I keep saying we, it's the royal we, it's really the Vancouver team. And so I think you can upvote these on Slido if there's a question you're particularly interested in. Or of course you can add a new question that will pop up on my screen here. So while you guys get your questions formulated and get your Slido active, I'm going to ask a tricky question, I think. So through your conversations and your learnings about the past, I wondered if you had any specific threads that you could identify for us around lessons that you might have learned or sort of patterns in the provincial and federal relationship in this space over time that we could think about as we move forward, as we've already heard that rhetoric come out since last Thursday as well.
Mm-hmm. Yeah, well, that's a good question, and I don't think I'm going to give a fully satisfactory answer because when I was doing this research, kind of like early aughts, as I guess we would say now, I'm a political scientist studying health policy in Canada. So obviously federalism is going to be a big focus of what I'm looking at. It turned out it wasn't. And to satisfy my committee, I had to write an entire section for the first part of the dissertation on why it was not a dissertation about federalism. And it wasn't a dissertation about federalism because I was looking at proposals for national or nationwide Pharmacare, and they never left the federal government, right? There's, as these proposals were discussed at the federal level and it was decided that they would not go forward, yes, there was conversations about, oh, the provinces might not like this or the provinces might not want to pay. But I'm hard pressed to think of a proposal before Bill C-64 that has come as far in terms of let's make agreements with the provinces, let's see what they're willing to do. So I think that is kind of why I'm not going to give a satisfactory answer to that question, because although there have been, I think, assumptions that federalism is going to pose a barrier to the development of a nationwide or national program, I think this is the first really meaningful test of that.
Mm-hmm. Excellent. Thank you. Thank you. All right. I think you can see the questions too. So I'm going to ask you the top one there is, where do drug coverage and ease of access fit into the fundamental framing belief that healthcare is a human right? The easy questions keep coming for you.
Yeah. Listen, I think that I would maybe ask that question back and say, who's framing healthcare as a fundamental human right? Because the thing that matters for getting policy change, I think, is how policymakers and governments understand and frame a policy area. So if healthcare is a human right, then drugs are part of healthcare, like full stop. But I don't actually think that that's the conversation that we're having about health reform in many instances.
Mm-hmm. Yeah, thank you. All right. The next question is sort of thinking about how any of the themes that you talked about in your talk show up in the other countries that you compared Canada to, and how are they overcome? Anything we can learn there?
Yeah, no, that's a great question. Thank you. So my research compared Canada to the UK and Australia. In the latter two countries, I only went up to kind of the mid 1970s because I was looking at how was pharmaceutical coverage or benefits implemented, and then sort of just the first few instances of reform. And I think that type of comparison is important because it gives us a different perspective on these ideas about costs. The UK included drugs, I should say England, included drugs in the National Health Service when this is implemented. This is also, like, frankly, going back to stuff that I have not looked at in a while. So yes, once the NHS was up and running, paying for drugs was a bit of a problem, as you know, as paying for the whole thing was actually. And the first sort of round of reforms in England were about, are we going to have a copayment or not? And we're going to implement a copayment, and then we're going to get a new government. We're going to take a copayment away, and then we're going to reintroduce copayment. So that conversation about costs happened, but it happened after pharmaceutical benefits were in place and their governments were actually saying, oh, okay, drugs are in fact expensive. And they had like worries about how are we going to get enough glass bottles for all these prescriptions. So like a very different discussion in the late 1940s and early 1950s. And Australia, I think, is even more interesting, and I think we're going to hear more about that this afternoon. But Australia started with pharmaceutical benefits. They, in the sort of towards the end of World War II, in the immediate post-war period, the government of the day wanted to introduce health insurance, but a lot of their doctors were overseas fighting in the war. And they're like, oh, we'll start small. We'll start with something easy and cheap. And they chose drugs for that. And they did not turn out to be easy and cheap. But again, it's just to say, I don't think Canadian policymakers in the 40s and 50s had some kind of like unique foresight about the way the cost of drugs would go, or at least if they did, it was not shared across these other countries. So yes, that is, I guess, a very long way of saying in the earliest discussions of health insurance, these worries about cost seem a little bit arbitrary.
Mm-hmm. Right. Thank you. And as you said, we're going to be picking up on that again later in our closing session. So excited to have that come back up. Changing directions a little bit, thinking about how you might suggest engaging patient communities in this current conversation around Pharmacare.
Yeah, again, a really important question and not an easy one to answer. I mean, my kind of starting point is that patient involvement is essential. And actually, if you'll indulge me, I'm going to tell you a little bit about how that kind of hit home for me in a different way after my daughter got her first continuous glucose monitor. People know what that is, right? It's a little device that people with diabetes wear to keep track of their blood sugar. So I had been studying public and patient involvement for a couple years. And Ellie was diagnosed, and like now she was 4. So she was very little. And she got a CGM pretty soon after. And And those are not covered by any sort of public program in Ontario where we live. And so I was like, you know, I know a little bit about the way these decisions about what should be covered and what's cost effective are made. I'm just going to look and see if the Ontario committee who's in charge of drug technologies looked into CGMs. And they had, and I don't know if it's changed since then because I haven't gone back and looked, but the report on CGMs in Ontario at that time was that they shouldn't be funded because there wasn't enough high quality evidence that they lowered A1Cs over time. And A1C is an important measure of blood glucose control. And I read that and I thought, huh. I mean, I know why they would focus on A1C because that's something that everyone with diabetes measures on a regular basis. And it's an important, like I said, it's an important kind of long-term indicator about control. But as someone with a newly diagnosed preschooler, the measure that I would be interested in is how are CGMs at allowing parental sleep, you know, or like keeping kids safe at school. She started kindergarten a few months after she was diagnosed. And so that's sort of an example of why I think, and I knew this before, I knew this from the research, but understanding it on a personal level was also instructive to me. And I think the main sort of caveat that I would have is that patient groups are sometimes, or their perspectives are sometimes, I think, discounted in ways that are not justified because of their financial connections to the pharmaceutical industry. And that's not to say that conflicts of interest don't exist. It's just to say it's a problem when there's sort of a blanket discounting. I mean, one way to address this would be to bring back public funding for patient groups, just an idea. But I also think patient groups need to be, patient groups and other folks who are involved in policy need to be really attentive to the way that when patients' needs and priorities coincide with industries, patients have the potential to make industries' priorities much more legitimate in the public conversation. And that's, I don't like, sometimes that's just going to be inevitable, but we need to pay attention to it because, again, this issue of whose priorities are legitimate, whose evidence is legitimate, whose ideas are legitimate is really important. And so I think patient groups have kind of a complicated position there. But their voices, like I said, their voices are essential. So we need to navigate that complexity.
All right, this next question be long, a long answer, but we're running short on time. So I'll ask you to, so the science of communications, including framing, is often overlooked. How did other countries frame communications to avoid this cost trap and a win for Pharmacare?
Okay, as quickly as I can, they didn't talk about costs they didn't talk about costs in the way that Canadian politicians did until Pharmacare was already in place. And once benefits are in place, it's very hard to take them away. So they developed supportive constituencies surprisingly quickly, I think, in the case of Australia, because there was an attempt to roll things back, but public doesn't want to give up free drugs once they got them.
And with that, thank you so much, Dr. Boothe, for the
Thank you.
inspiring lecture. And thank you to Dr. Sue and the family for their generous gift, which makes this lectureship possible.